Roselynn Omolloh is the CEC for CCM for Homa Bay County for Health. She's a devolution expert. Like we said earlier, as we were introducing and talking about her coming. She served in the Senate in the last administration. In the previous one, she served in the Council of Governors. So in terms of this devolution story, when devolution started, she was there at the technical side, and then she went to the national oversight side. Now she is in the county executive side. City.
Yes, please.
Why don't you give her the day's proverb as an introduction?
I will. Our proverbs for the whole of this week, ending tomorrow, are from the country of Namibia. Now, today's proverb is a fairly simple one. If the state is going to fall, it's from the belly.
If the state is going to fall, it's from the belly.
Yes.
Madam Waziri, good morning.
Good morning.
Waziri, eh? How do you feel?
You have to call it in the Luo Wasiri.
Wasiri. Masmiwa.
No.
Karibu.
Wasiri.
Wasiri. How do you write Homa Bay? You know, there's always that confusion. Is it Homa Bay, 2 words? Homa Bay, 1 word?
It's Homa and Bay.
Yeah, see, Bay is like a...
Sawa, but have you ever seen people writing Homa Bay as one?
As one. I've seen it, but it's not. Doesn't mean it's correct.
Thank you. That's what I was going to say. Doesn't mean it's
That's
correct.
what I was asking with the correct one.
It's Homa and Bay, 2 separate words.
Homa and Bay.
Yeah.
What is Homa?
Homa is a place. So when you come to Homa Bay, and I hope you will one of these days, I'll show you. So there's Homa Hills in Homa Bay. So it's the name of a place.
Okay.
But so we have the hills actually right behind the county headquarters. There's a small hill, that's the Homa Hill. And then now we have the Bay. So we are, of course, people have corrupted it with the Homa, the word Homa as we know it. But that's not the whole purpose.
That's not it, eh?
No, that's not it.
Okay.
Yeah.
And the people of Homa Bay are very proud.
Very extremely proud people.
Complete proud. Eh?
Well, we are not proud.
Eh?
I think you're using
I'm
the
not
wrong
saying
word.
arrogant. I'm
No.
just saying you're proudly Homa Bay.
No,
Homa Bay.
there's a Luo word
Yeah.
that you cannot actually
Translate
to English. So when it's loosely translated, it's proud, but that's not it. It's called Nyadi.
Confident.
Nyadi, exactly. You know, the words that you explain better.
It's the wherewithal.
Thank you.
Yes.
But because that's a very long word, so you people resort to say we are proud. We are not proud. We just have Nyadi and lots of it.
Lots of Nyavi.
Lots of Nyadi. So you are now serving in the health docket of Homa Bay County.
Yeah.
We saw your governor going around and looking at the health facilities and saying there's some work that needs to be done here. There's progress that needs to be made. There's addressing the people's needs. Tell us, let's start with that. A review of what you found. You know, even Rigiji has told us they found, it's Cherarge who told us they found 80 bob at the treasury. Something like that. What did you find when you took over as CEC for Homa Bay Health?
So, first of all, we found health not where it should have been, or not where it should definitely not have been, especially 10 years into devolution, after 2 terms of devolution. So what do I mean? Even in terms of infrastructure, we had dilapidated buildings, and the dilapidation was on such small levels, the simple things that could have been repaired and looked after. That was not done. But the greatest problem was lack of commodities. And the greatest was the morale of the workers at the time Her Excellency Wanga took over. I am a strong believer in the human resource component for health being even more important than the commodity side, because as we know, health is a service. If any of us faints here now, God forbid, we don't need a hospital as much as we need a medic. So if you take care of the medics, then things are sorted. So first of the things we found was morale was at an all-time low, because workers were going without salaries for as much as 3 months. And so, you want to ask yourself, do I go to work or do I look for money for food?
food.
Do I find food for my children and my wife if you're a man, or do I go to look after people who are sick? We also now therefore had, because of that, a lot of issues of cases where people tell you that staff were asking a patient to buy them food because honestly they did not have the money. And this is something that I'm not exaggerating. These are real life stories that now in my interaction with my colleagues in the health department, they have told me. So the first thing that the governor did, and she made that promise even before we were brought into office, because she was the first one to be sworn in well ahead of us, she promised them that they would be paid on time. And as we speak, there is no month that has passed since Her Excellency Wanga got into office that health workers have not received their salaries on time. So this has in a way restored what I would call their sense of security, of tenure, and has given them some joy to do their work with knowing that they are felt, that they are, somebody cares about them, they're appreciated, and somebody even notices that they are there. Now, because of that, and because the second step was now the issue of commodities, now our hospitals are overflowing. I'll give you an example of the county referral hospital. The first time the governor went to that hospital when she got into office, I think there were 6 patients, or at most 8. The beds were empty. It was like a ghost town. Right now, the biggest problem we have is traffic flow. We have too many patients. We have a 260-bed facility. Half the time, we have more than the 260 patients. Patients are willing to share beds because they know that they'll get the service. We have never run out of drugs. We used to always have constant matching, health workers matching in the street. That has never happened since we took over, and it is not going to happen for the longest time because staff are paid on time and paid as they should be paid.
Why were these delays happening?
I would say
And was it only in the health sector, or was it across board with all the workers for the county?
It may have been across board, but I would want to talk about the health sector. I think for a lot of, maybe let me talk about the counties in general. As you said, Eric, I have been in devolution since day one. So a lot of it, I would just put it down to governance. And so one of the things that Governor Wanga's government is very strong on is governance, establishing the governance structures in the counties. When I talk about governance, it's just having, infusing the normal best practices into everything that you do, like ensuring that the payroll is prepared in time, it's closed in time, the funds are sourced in time. So I really do not want to talk much about the previous government. I was not a part of it. But I guess they just had different priorities, because I honestly don't see how personal emoluments would be at the bottom of the priority. Because even when you look at it, it's what I would call the first charge. It's the first withdrawal from the consolidated fund. That is why whatever happens, even when we close the financial year and we are not paying any money for development, but we still have a recurrent vote. And the Controller of Budget still approves that, and Treasury still sends the same.
Is it... Okay, in your whole journey in devolution, the one constant message that we keep getting from governors is delayed disbursements from the National Treasury. How does that affect the operations of counties?
It affects operations of counties to the extent that first, in terms of development especially, you cannot develop by installment, as the very first chair of the Council of Governors, Isaac Ruto, used to say. So if my budget for development, let me talk about my docket. We are putting up an accident and emergency center in the referral hospital at a cost of 100 and something million. So if that is my budget, then it means from the minute that I sign the contract with the contractor, then we should have the 100 million somewhere, But if you're going to pay 10 million and then you release another 12 million. So it means we will always, as counties, end up closing the year with unpaid bills.
Yeah.
We'll end up incurring pending bills because we have to keep shifting money. So one, it makes it means that the counties cannot plan. You cannot plan effectively, and even when you plan, you cannot execute your plan. You can't work your plan. You have a plan, but you can't work the plan because it's sort of like you depend on someone else to make sure that your plan works. So the delays are really affecting especially development. And there were instances where governors complain about roads. For instance, you've started Maraming a road, then somewhere in the middle, the money stops coming and a new financial year starts. So like if you give a road contract today, this is February, that road must end in May, meaning the Treasury must release the money between now and May for the county to be able to pay the contractor and to finish the work. Because as you know, construction, you pay according to certificates. So they do some work, you pay, then they continue and you pay. So because development cannot be done in bits and pieces, counties suffer when the National Treasury does not remit the monies in time. We also don't understand why this happens because having worked at the Senate, I know that once the Division of Revenue bill is passed, then the Senate sits down and does the schedule of disbursement. So what we don't understand is why is it not possible for the National Treasury to follow this schedule of disbursement? Of course, they keep saying, it depends on how the money comes in, how we collect taxes. But when you look at the national government budget and you look at the disbursement to counties, come on, it's possible to put aside 150 billion from day one and say this money is ring-fenced for counties so that it's disbursed as you collect, as KRA continues to collect maybe the next 3-4 months. And then you make sure that at the very beginning, if I was the CS Treasury, I would make sure that the money for counties is there and it's ring-fenced. It's just not maybe released into the county revenue accounts before, but it is available as and at when they request for it. Yeah, because the schedule of disbursement is there and it's approved. And if it is not going to be possible to adhere to that, then can we have a conversation? Because this is normally done before the new financial year. Yeah. Like now, Senate is working on it, and they're going to pass the CARA in a while. Is it possible at that time for the CS Treasury to say, "I'm sorry, we are not going to be able to do this, so let's space it out like this"? But when we don't have conversations, and remember, Eric, these are governments. These are 47 governments. So when we don't have that kind of mutual understanding, then the counties run into a lot of headwinds for no apparent reason. Thank you.
As you're speaking about the challenge, obviously the challenge of releasing of money from Treasury, because we know that without that money, so many things are halted at the county level. Yeah. Now, if we're looking at health, it's very clear. Some of the things that you've already promised to people, paying your salaries on time, making sure that the commodities are available at health centers. What other challenge? And those are things that you've told us. What other challenges then are faced at the county level at Homa Bay County when it comes to health? I asked that question because, again, you can't talk about things that happened before you were there, but the broad picture that we got was that, things were just nothing was working. People walk into hospital, they cannot get medical supplies. They maybe will see a doctor, maybe they will not. There's overcrowding. So apart from release of money from Treasury, from a health perspective, what other challenges do you see that need to be overcome and how?
One of the challenges that I would, and that's what I would refer to as the whole matter of resourcing health. It's not just about the finances. It's about even the human resources and the distribution of the same. When we transferred health to counties in 2013, I do not think that certain things were done. The best thing, of course, this I must say, the best thing that has happened to health, despite everything, is devolution. Because a lot of gains have been made. I'll come to that later. But at that point, when we devolved, fully transferred the health function to counties, we did not, for instance, establish how much would it cost to carry out health in Homa Bay versus Nairobi. We are talking about reach, we are talking about spread, we are talking about the geographical dispersity and everything. So for instance, for a county like Homa Bay, we need to, we despite all this, one of the challenges we are still likely to have is the human resource aspect. We do not have the correct number of qualified health workers.
Is this because they are not available, or because we've not gone through the process of starting to hire?
We are going to go through the process of starting to hire, but before that, we have a very bloated wage bill. When you look at what the ratio, what's supposed to happen, it's supposed to be 70-30. We've already surpassed that as a county, especially in health. So we have a scenario where we have 2,200 and something health workers. But of those, only 1,400 are actual health workers.
What do you mean?
What I mean is we have other general
people who are what?
We have general categories. We have clerks. We have others.
Okay.
Yeah.
Okay.
And when you look at
in
it,
accounts, administration,
exactly,
but it's all under health.
It's all under health,
right.
Because when you're employed in a government, you are taken to a ministry, even in the national government.
Yes.
So that becomes your domicile ministry. So we have those excesses that we must trim, that we must address, that we must discuss, that we must agree whether as a ministry, a department, we are releasing them back to the county public service board for deployment to other places, so that our wage bill is exactly what it needs to be. We have 232 health facilities. This means that we have facilities where you only find one nurse. Yeah, and the other challenge that there is also the Ministry of Health is responsible for quality assurance and standards. But I keep asking myself, is there a conversation they've ever had about, for instance, I know counties will say, oh no, we are independent and we can only do consultation. But if standards and quality assurance comes from the Ministry of Health, then it's possible for us to have a discussion around saying you cannot continue building health and facilities.
Yep.
You must now stop building for health facilities and build your workforce. Because what is a dispensary or a health center without a worker in it? Yeah. So these are some of the things. Like, I think one of the things that the Ministry of Health needed to have done is just break it down very simply for people and say, Nairobi, this is your square kilometers. Even if your target is to have a health facility within this radius, then it means now you've exceeded the radius. So now stop building and equip and
make sure they work.
Exactly.
Put the facilities in it.
Yeah.
Is there no such document in the Ministry of Health? I mean, is there no such plan, nationwide plan on what is our health plan?
I have looked. If it is there, it has escaped my attention. But I do not think it is there. Because when you look at when you look at it, this is something which needed to have been there. Like in 2017, when now the Health Act was being reviewed to accommodate the transfer of health function, when we even had the directors, because the Ministry of Health then realized, for instance, that counties were changing CECs for health and chief officers. So they wanted a linkage that is constant. And so that is how they came up with an amendment that said the Director General at the Ministry of Health would deal directly with the Directors of Health in the counties. So that we have that grounding, we have that consistent flow of information, and so on and so forth. And also for purposes of the professionalism, because I am not a doctor. There are instances where the CEC is not a doctor, the chief officer is not a doctor, but they still need a medic to understand these issues and propel it all the way up to the end. So that's one of the issues. The other issue is training for health workers. Now, at the time we devolved health, we simply transferred the IPPD from national government to the county government. So if you're in Nyamira and you had been a doctor in Nyamira for 3 years, 5 years, you're stuck there. Yeah. And also the county public service boards do not allow cross-county transfers.
Why?
So it means that's just the law. That's just how it is.
You're hired by Homa Bay.
You're hired by Homa Bay, or devolution found you in Homa Bay. You stay in Homa Bay until you retire. So I am sitting here and I'm looking at myself and thinking, I'm a health worker, I'm a doctor in Homa Bay. Do I really want to work in the same place all my life? Because if I move and I want to go to work in Lamu, then either I lose my benefits or I start afresh in Lamu. So one of the difficulties is that growth. But also in terms of training, one county might not have resources to train, while another county has resources to train. But now, since you're not able to move, it means you stay there, you can't go for further training. And also because of the numbers, again, we are unable to to train, because we need to provide a rotation so that when one person is away, then the other people covering for them and their duties.
Rico, we want to break?
We have a minute. You can ask a question.
Okay, I have around 15 questions, but I will condense them to 3.
Ask one, then we do the break.
1. The partners you have in the health sector, what is their role? How do you move forward with them in meeting the needs, the health needs that the county has? That's question 1A. Okay. Can I ask 1B?
No, let her answer that one.
Is 1B related to 1A?
Yes, they're all related.
All 15 are related.
No, but I've condensed them into 3, but this is just 1.
Yeah, I think for lack of a better word, in Homa Bay specifically, the partners have held health in Homa Bay. If it were not for the partners, I do not know what we'd be talking about. I'll give you a very quick example. The Bamako Declaration made it mandatory for primary health care to be affordable, and it actually proposed decentralization of health to the village levels. If there are people who have helped us to execute and to realize the Bamako Declaration,
yes.
It is the partners in Homa Bay. Homa Bay is the only county, and I say this very proudly and loudly, with 100% community health volunteer cover. Where people say, every 5,000 people should have 10, this number of health workers. No, we are doing better. We have a health worker in every, we have several health workers in every ward. So if you look at 2,954 community health volunteers, and you look at the population, which is about 1.2 million, not all of them even live in Homa Bay. Then you realize we have more than 100% health workers. This has been possible with the help of partners. A lot of our facilities have been supported by partners. Even as we came in, AMREF, through M-Pesa Foundation, built for us a whole maternal facility in Dewa. A very beautiful one, which the governor opened in December and handed over to us. They have also helped us with some equipment. So the partners have done a lot. Now, how are we working with them? We are now getting into a space where we are going to develop a framework for partnership. We had a meeting in December and we agreed we must line behind each other. If you're doing HIV and AIDS, please sit down, agree. We are not rewriting any government-to-government agreements. We are not rewriting any program documents, but we are saying, can we consult? Can we work? For instance, with the CHVs, the community health volunteers, if we are going to my village, for instance, and you need a community health volunteer, can he also come on the same day? And can she also come? Because you're doing the same program, you're going to the same place. Why do you go on a Monday, then he goes on a Tuesday, and you go on a Thursday? Can we synchronize? Can we have some cohesion? Thank you.
Good. Break. So, point of information now. Tell her about Minute Bread.
Right. When we are engaged, the sort of discussion we're engaged in, which clearly points towards it getting more and more intriguing and more interesting.
Yes.
Sometimes just to give your mind and your system a break, you need a drink that energizes you. Aha, you see? She has got it. You see? She knows. It gives you the moment. You feel, kweli. Now, that's what Minute Maid does.
That's it.
And you have a choice. Nectar mango, pulpy orange, apple, etc., etc.
Water.
Tropical. 28 minutes to 9. Let's take that break in the Situation Room. Our guest this morning is Roselynn Omolloh. She is a County Executive Committee member for Health in Homa Bay County. Wasiri wa afya kutoka Homa Bay. We are talking about resourcing health, financial and human resource for health. What is it that we need to do to make sure that healthcare is actually working to the best possible way in all our counties? We'll be back shortly. Good morning.
This is the Situation Room, the only way to start your day.
Roselynn Omolloh, City. Question number 2?
B.
1B.
Yes.
Okay.
Homa Bay has the unique and the wonderful distinction or being one of the few counties in the country that have a partnership with actually PEPFAR. Okay? Now, what I'd like to understand is how this is going to work out. Now, let me explain why I'm asking this question the way I'm asking it. You may not have found documentation that would help you with an overall plan of how to move forward, but the Ministry of Health has health economists. They also have costing experts. Now, I believe that these are the sort of individuals whom, if engaged, would be able to give a very clear way forward on how best you can deploy the monies that is allocated to your particular ministry and how best that can actually be achieved. Why do I say this? Because the talk we hear, not just with health, but with most ministries, even at the national level, is that the money is not enough. So I always ask, okay, it may not be enough, but the one that we get, this one which is not enough, how do we utilize it in the best way possible, and how do we explain it? Now, again, I'm going to give it another rider. It's in Homa Bay County that the research for the Integrated Community Health Case Management, ICCM, that dealt with pneumonia, diarrhea, and malaria, and the use of health workers, volunteers, such as the ones you mentioned, to try and see if syndromically you can actually manage these things among children under the age of 5 at that point in time. And what that research did at that point in time was it proved that you actually reduced hospital attendance by something like 75% now. So when you told me you have 100% cover of healthcare workers, my joy was complete. Because this is the question. When you have such a cover and you have such personnel and you have partners, I'm tying this together, is it then not possible to ensure that those primary ailments that can be dealt with at the village level are actually dealt with conclusively so that they don't grow into the sort of ailments that require hospitalization and by so doing burden the health system?
You know, you have actually answered the question. You asked it and then you answered it.
That's the general idea.
Because that's exactly what we're doing. And that's the exact reason that Her Excellency insisted and was very, very purposive about introducing the community health volunteers, and not only introducing them, but paying them a stipend by the county so that we are... It's public knowledge. We are paying them 2,500. 2,000 is theirs. 500 is for their NHIF cover. So they also will be able... I mean, you can't be the one driving traffic to hospital for referral and you cannot access that facility yourself. So our community health volunteers will be able to get medical attention if and when required. However, we have gone the way you're prescribing. And for instance, you know, maternal health, all the complications that we have about maternal health can actually be eradicated by a single stroke of just empowering the community health volunteers. These people work in the community. They speak the language of the community. They are known. They know the issues.
They're trusted.
They are trusted. They are the first point of information. And so that's why we are strengthening them. And yes, for us, even as we do all the work we are doing at the referral facility and our other level 4 facility, and even all our facilities, our biggest aim is to bring to life the issue of primary health care, and not just primary health care in terms of the facility, but at the village level. And so we are working with an organization called Healthy Entrepreneurs, who have already trained for us some some volunteers, and we are going to kit them so that they have the basics and the basic knowledge of dispensing this knowledge in a way. And the other day we were surprised when someone told us that most of the diseases in Homa Bay are preventable. We're talking about waterborne diseases.
Yes.
Even now, as I live here, I'm heading to Safari Park for a meeting with UNICEF on KESEP, the issue of open defecation, the issue of having toilets, the issue of reducing, diseases that come out of just poor hygiene. We have the University of Nagasaki partnering with us on issues of jiggers and so on. So our our community health coverage is very all-inclusive, and our approach is so multidimensional that we want to ensure that as few people as possible actually get to hospital. Because when people do not have to spend time to go to hospital, then you know that your healthcare systems are working. Small little things should not let you walk to a hospital and spend time there waiting to be seen. Yes, you asked the question and you answered it. We are doing exactly what you have prescribed.
We are of the same mind then. Now, HIV,
Yes.
the prevalence of Homa Bay has still been disturbing. How are the partnerships helping with not just controlling it, but reducing the incidences of HIV?
The day before yesterday, I'm a storyteller, Eric knows, so I start my answers with a story. The day before yesterday, we had a cocktail, a dinner, or a reception, whatever you want to call it, where my governor, who is also the Council of Governors Vice Chair on Health, was representing the council. The function was 20 years of the Child Investment Foundation. And the founder told us a very sad story that 20 years ago he went to Homa Bay and he wept. And he says actually he was motivated to put more investments into children because of the experience he had in Homa Bay. Of course, what I'm trying to say is 20 years ago, the HIV/AIDS burden in Homa Bay was terrible. And for Eric, you might not know, when HIV and AIDS was first declared in Kenya, there were only 2 testing centers and 2 treatment centers. One was in Nairobi, one was in Homa Bay. Fortunately, it's not something to take for granted. We have what we'd call patient number 001, the first patient who was diagnosed in Homa Bay who is still alive because of ARVs. To answer your question now directly, the partners have done a wonderful job. And one of the things that I would want to say, and I'm not running away from the statistics, when we talk about 3,000 new cases of HIV/AIDS, and when we look at where we've come from, for me, I want to dwell on the positive story, that these were not the numbers that we were seeing way back then. That is one. 2, because of the programs that partners have brought on board, like the prevention of mother-to-child transmission. Last year in December, on 1st of December, when we marked the World AIDS Day in Rachuonyo, we graduated 130 children born to HIV/AIDS positive mothers, but free of HIV. If that is not a success story, I don't know what a success story would look like. But our partners have done so well that, for instance, we have the most important thing for me, because I'm a communications person. So for me, dialogue and being open about these things is the most important. We had skits where people are openly talking about ARVs. We had patients who know they are now on the 4th line of intervention. That is something that would never happen before. And this has all been possible because of partners like MSF, like LVCT, to mention but a few. We have groups. We have groups like Commercial Sex Workers Union talking very openly about condoms and condom use and saying, our biggest challenge is the type of condoms that we receive. So for me, when you're having conversations about something, because that one of the challenges that our community we had about HIV/AIDS, it was taboo to talk about it. We don't discuss sex. We don't even insinuate stories around it. So it was not a discussion that we could have. And if somebody had HIV and AIDS, they were condemned to die. There are people we stayed away from. So for me, the movement that we have made, the steps that we have made, they're not enough. We still have a lot of work to do, but we are not where we were when we began.
Sure.
Yeah. Also, you also might consider that there's what we call migratory testing. There could be people coming from other counties to come and test in Homa Bay because we have the best testing facilities. Yeah. And also because HIV/AIDS is such a private thing, you don't want to go to the health center next to your home and then someone starts pointing at you with the nose that he came for that.
Have a community discussion about your health data. Are you able to look at the county and say, it's my turn to ask question 2.A and 2.B. Would you say that most people who walk into a health facility in Homa Bay County today are paying out of pocket, or are they covered by NHIF?
So we have 2 if you're coming for outpatient, there's what you pay and there's what NHIF covers.
Yes.
So but even when there is a payment, the payment is still very minimal.
Okay.
So we have cash for outpatient for certain parts of outpatient, whatever processes and procedures, but there's also what NHIF covers. So it's a hybrid of it.
How would you like it to be? And I ask this question because NHIF tells us all the time that they're doing, drives. They're trying to get more and more people to get on the grid, do your contributions on a monthly basis so that in the event that you are unwell, we can then, we can sort this out. So there's no out-of-pocket spending. There's not the proverbial harambe where people are putting money together to pay for somebody's health. So that's why I asked the initial question that people who are coming into hospital, are they paying out of pocket? Then looking at what the burden is, we know what it is when it comes to, how much somebody can pay for, health management, medical attention. What would you like? What would you like to see it be? And then what are the, inroads to making sure that it happens, that somebody can walk into hospital with a card and be covered?
What I would like to see is that people walk into hospital and walk out of hospital without either digging into their pockets or calling their relative who has deep pockets to bail them out of it. We want to thank the national government through UHC. We have, in the last 1 month, I think it's for all counties, we were given an extra, the phase 2 covering 20,000 households. So when you bring that on board, it means about a good number of people. So Homa Bay, we have already submitted our list and we've upgraded 20,000 other households. But we are still negotiating. And one of the things that the governor is doing is, you see, for my governor, her whole health package is a package. So she calls it Genoa Care. Genoa in Kijaluo is, do you want to translate
Geno
that?
is hope.
Hope.
Yes.
Wa is ours. So our hope. So she has this Genoa Care, which is basically that whole package around health. And one of the things that we are doing is a serious, intentional and very purposive drive to have people register on NHIF, because in the long run it's cheaper. If you are able to send even as little as 1,500 shillings to your relative in the village per month, they will be able to have NHIF cover. Then they don't have to call you every time they are sick, and that's what we are trying to tell people. So we are having concerted efforts, and it's a partnership that we are going to do with the NHIF, and we are going to use our community health volunteers to try and aggressively market, and enable people to be purposive about taking health insurance. So it's something we're doing. We are going to roll it out later this month, the second half of this month, and it's going to be a drive that's going to be running for about a month, so that we ensure that as many households as possible are registered on NHIF. Yeah. But in the meantime, also on our side as government, we have now gotten NHIF accreditation. Last week on Thursday, we were with my governor. Had a meeting with the CEO of NHIF and his team, and all our 232 facilities are now accredited on NHIF. So that means when you walk in, you don't have to pay.
Yes.
So that's our way of now encouraging people and saying.
And when people walk in, they will not be told, yes, well.
No. There will be no
issue
stories.
With
there will
NHIF,
be
so pick
system
careful.
go down.
There will be no, Eric. Our systems are zikwangi down.
All the time. What's your governor and your position on the push by healthcare workers countrywide to have a National Health Services Commission?
I'll talk about my position. My position from the beginning has always been that that may have been necessary those many years ago for reasons that people thought were not very serious. But when you look at it, all those issues I've talked about, training, movement, and so on and so forth, I actually think it's a conversation worth having. In 2013, one of the issues that we had with the unions then, and I was at the council, I was actually the technical assistant to His Excellency Ongwae, who was the chair, Human Resource. And the first issue we dealt with was the health worker strike. We felt at that time that doctors did not want to be supervised. And actually, that was the truth. And I understood where they were coming from.
What do you mean they didn't want to be supervised?
They didn't want to be supervised in this manner.
Yes.
You see, look at how things were run before. So you work in Kisumu, you'd find there's one particular, and I shall not mention, but he was an official of the union who was in Nairobi, but based in Vihiga.
So his salary is in Vihiga.
The salary is in
comes
Vihiga.
from Vihiga, but
the salary comes from Vihiga, but he's in Nairobi. He's doing locum here, he's doing there. It had to be a man, yeah? Mm-hmm. He's doing locum here, he's doing locum there. And yet, he is now with the transfer, it reads that he should be in Vihiga. So why I'm talking about supervision, it means they would have less room to do anything else other than work. Because how many doctors does a governor have? The governor can literally know how many doctors went to work and how many did not. So at that point, we thought that was the problem. But when we looked later and on further negotiations and on further discussions, and having also been worked with trade unions a bit and understanding what collective bargaining agreements are and about and everything, there was much more. The doctors were looking at a more long-term proposal. So for me, I would think the National Health Service would help, but it can only be done in a way, Eric, that does not disadvantage any counties. And I say this, with all due respect to the medical fraternity, we've already gone so far in devolution that if having this service means that you're going to change the way things are done and the way things are run, then you're going to run into trouble. Because then, how are we going to have doctors working in counties but answerable to someone else? There's also something about that collective responsibility and accountability and, the issue of who you report to. So if it can be done in a way that helps us manage this, then I would have no problem.
How do you propose that is done? So I'm hearing two things. One, you acknowledge that having a National Health Services Commission helps, number one, to make sure that there is equitable distribution of the available health resource in the country. Number two, if it's in terms of training and then that rotation that you're talking about, if a doctor is removed from your county to go and train somewhere where there is a facility for training, another one will be brought to cover your needs. But at the same time, you want to be like the CEC for health, you want to ask questions and get answers. So how would you like now that balance to be struck? What is it that you'd like? Is it?
I would like to see doctors have movement, both in terms of promotion, both in terms of opportunities, both in terms of, also in terms of training and so on and so forth. But I would also want us to have a situation where we have accountability and answerability at the local level. How that can be achieved is what I do not know. But I am sure it can be worked out and I'm sure it can be achieved. So that even though you are employed or you're responsible to the National Health Service, but you're still answerable. But for me, this would really be a long shot. For me, the easiest way to go about this, Eric, is to just have a situation where we declare the county public service public. Yeah, as I said when I began. And it's one of the things that Governor Ongwae really pushed for. So that if, in terms of growth, because people are also going to school privately. So let's say I am a surgeon or I'm a medical doctor in Homa Bay. And then I've gone and I've done a master's in health financing or health economics. And Turkana needs an health economist who also has a background in medicine. So there's opportunity for me now to go and practice what I feel as my next steps. But because of the way things are today, I am unable to.
You cannot transfer.
Yeah. So even if we talk about the National Health Service Commission, it's not a panache. It's not going to be. It's not a bulb. It's not a switch that's going to bring to flood the room with light. It might actually bring more complication. For me, it is. Let's look at the bigger picture. Let's look at even speciality mobility so that I can move from this to the next and I'm able to do something else. So then we just need to look for a framework to declare county public service public so that people can move from one county to another if and when the opportunity arises.
Now, the other day we were discussing this. Yesterday there was the IBEC meeting, which still ended up with a stalemate. Governors want over 400 billion shillings. The national government is saying 380 billion. Chukweni hiyo bei ya jioni. Hiyo tu ndio iko. Tutaongea baadaye. Now, 380 billion shillings, that goes to cover everything in devolution across 47 counties against the national government proposed budget of 3.6 trillion shillings and over 200 billion shillings going to the health docket in the national government. What's your view on that?
I would, for lack of a better word, I do not understand how the national government wants to stay committed to devolution if the financing and the funding is never going to increase. Did you know, Eric, that health alone, the Council of Governors, because as I said, we did not cost functions when we transferred them. So the Council of Governors got an expert who did for them a functional analysis of the cost of executing health in all the 47 counties. It comes to 304 billion. So that means out of 380 billion, how much are we linked for the other services? And when we talk of 304, I am not saying that we're going to have hospitals that look like Nairobi Hospital or Aga Khan. We're just saying proper cover. When you talk about universal health care, we are talking about access. And even as you access, there must be a service. You're not just accessing the health facility. It's access and availability. So for this to be achieved, we need 304 billion in all the 47 counties. When we started devolution, what was the first amount that was disbursed? How can we collectively move in 10 years with less than 100 billion, less than 200 billion, and yet we say we are committed to devolution? It gets to a point you want to ask yourself, are we serious about devolution, or is it an inconvenience that we found ourselves in as a nation? Secondly, why do governors have to always go to bargain for what they need? Isn't there a way for us to determine, the way the national government said, for us to spur economic growth, we shall allocate this amount to this. For us to do this, isn't it possible that devolution should also be in their, in their focus? And they say, for us to grow devolution to the next level, we shall be giving this amount to counties. Of course, I have been in Parliament, and the noise that sometimes came, especially from the National Assembly, was that governors are stealing money. We're just taking more money to the counties to be stolen. There is somebody who said 15% of an elephant is not 15% of a chicken. I am not saying that counties do not have problems. But I'm saying if you take more money to counties, you are still helping the nation in a different way. You stay up here with the money. Is the money now kept safe? I mean, we are government. We are not in the business of saving money. I'm not saying we do not observe prudence in use of public resources. But I'm saying, can funds follow functions?
Yes.
We devolved functions. Why can't resources follow functions?
Well said. Waziri, thank you for joining us. Roselynn Omolloh is the CECM for Health in Homa Bay County. She's been our guest this morning. Asante for joining us.